All right. Hi, everybody. Welcome to February office hours. Appreciate y'all joining us today. We'll get started. We're recording as always, and hope everybody can see the slide deck. Can I just get a confirmation that you can see it? Yes, yes, yes. Yep. Okay. I see Taco Tuesday from Marcus on there. All right, Marcus. Taco Tuesday it is. Um, we got the chat feature obviously functioning for folks. We got a lot of those answers, so thank you for that. That's there for people along the way if you need to use it. Any questions, comments, thoughts, please use that for that. Also, if you want to chime in along the way, please do so as well. If we have anything you want to mention, and we'll stop and take questions, comments along the way. And we are going to start into this month's agenda. Policy and procedure updates as always. We'll get into some quality management, performance, and compliance stuff. Children's updates as we always do, and then some other stuff that we have for this month. So we'll get to it here. A lot of policies and procedures again this time of year. We have that. So we'll go to that. Jessica, if you wanted to start diving in.
Hello. So today we're going to just be going through what's on the left-hand side. Some of these are just annual updates, so there were no modification to policy. So hopefully we can get those through pretty quickly. On the right-hand side, we do have some upcoming policies. Hopefully this is going to be the last large push of updates here in March. And then after that, we'll just have some one-offs, fingers crossed, but you never know with DOH. So upcoming, we got some incident reporting, HARP. HARP is being updated for minor tweaks, and there will be a separate training for that HARP oversight policy. We have care transitions, the complaints policy, Health on Plus for SMI and AOT, conflict-free case management. And thank you to all of the CMAs out there that got me your internal policies for that. So shout out for being compliant there. We'll also have the billing policy, the children's billing and core services policy that will have its own special training on March 17th on a Monday. So you can join me on your St. Patrick's Day. We will have the transfer process between OPW, DD, and DOH waiver. And the SPOA high fidelity wrap HCBS referral process. I will do a light touch on that during children's updates, but that will be its own new policy that will be coming out. Go to the next slide, Travis. All right, so for CANS and the UAS assessments, this was an annual review. However, this kind of solidified the policy about the updating training components that moving forward when you do your annual certification, that you're going to have to take that booster training, and then you're going to have to complete your certificate for 0 to 5 and 6 to 21. We've been talking about this for a while, so that's not new business. It's just now officially in policy. And then there's going to be updated language in there for specifically folks that are enrolled in high fidelity wrap. As you all know, your CANS is completed every 12 months, unless there's a needed cause to do it sooner. But for kids who enrolled in high fidelity wrap, the expectation is that they are having a CANS completed every 6 months. So we will have specific high fidelity wrap policy coming out, but you will start to see some of that integrated into our children's policy. Any questions on the CANS and policy that we got going on? All right, go to the next slide. All right, another one for kiddos is our children's HCBS waiver authorization policy for fee-for-service members. This is a brand new policy for those folks out there that serve children and for children who are enrolled in HCBS and those kiddos who are enrolled in fee-for-service Medicaid, so they do not have a managed care Medicaid. With all of our members that are enrolled in HCBS and who are receiving service, all of them have to have an authorization form. That's where you get frequency, scope, and duration. That's for everybody. All authorization forms are to be completed in IRAM. So every service provider will be putting their authorization forms in IRAMs. That is also going to be for fee-for-service members. The Department of Health is going to be the ones who approve the frequency, scope, and duration for our fee-for-service members. So before pre-auth and IRAMS process, the service provider would just kind of update the form, send it to the health home, send it to the care manager, and then you guys would update that frequency, scope, and duration. Future state is the provider, well, actually current state now. The provider is going to fill out that authorization form, post it in IRAMS, and it will be approved, partially approved, or denied by the Department of Health for the folks that are in fee-for-service. If the member is in managed care, that will still go through the managed care process. And then just to keep in mind that you should never be updating a plan of care if you do not see that form in IRAMS. If a member or a provider emails you, verbally tells you what frequency, scope, and duration is, please remind them that the form needs to be completed in IRAMS. And then once you do have that form in IRAMS with frequency, scope, and duration, the plan of care must be updated within 10 days to include frequency, scope, and duration. So this is a new policy for our fee-for-service members. However, the process has been the same for our managed care members, and this really is nothing new. It's just formalizing that DOH will be approving those authorizations for our members enrolled in fee-for-service. Does anybody have any questions on this? All right, you can go to the next slide. So our next slide is, we're going to keep rolling with our HCBS youth. This is the adaptive assistive equipment and modifications policy, so environmental and vehicle modifications for youth that are enrolled in HCBS waiver. So this is an entirely new process that is in here, and this is an approved pending policy because this has not been formalized by the Department of Health. There's been a lot of communication from me, from the health home, instructing you on the new process. I formalized it into a finalized pending policy. So this shouldn't be anything new. We've had this instruction, I believe, since July of 2024. In there, you'll note that if you would like to pursue any of these modifications for any of your HCBS enrolled members, the first thing you're going to do, as you have always done, is have a documented conversation with the family, make sure they're issued those tip sheets about modifications. If they'd like to move forward, you're going to go ahead and put it in the plan of care. New, well, not really new, but now formalized from July of 2024, you're going to reach out to the financial management service system through the FMS. That system is Chunny. The link is in the policy itself. It'll take you to the web page. You will put your request in there for the modification, and then all of the steps will be handled between you, Chunny, and then potentially the provider who's doing the modification. The health home in the Department of Health have been removed from this process, and this is going to be for fee-for-service and Medicaid managed care members. So if you would like to loop the health home in on your communication, you absolutely can, but future state, this is going to be between the care manager, FMS, and potentially whoever the provider is that's doing that modification for you. Does anybody have any questions on this update? All right, you can go to the next slide. This is another brand new policy that's hot off the press. This is our Homeless Youth Services Consent Policy. This policy really formalizes what to do if you have a member who's under the age of 18, so they're not self-consenting, and they don't fit in one of those self-consenting categories. So if you're under 18 and you're pregnant, parenting, or married, you can self-consent to health home. But what about those kiddos that don't fall into one of those categories and they do not have an identified caregiver because they are considered homeless youth or runaway youth? What do you do then? Well, now we have a formalized policy that allows you to self-consent them to health home on the 50-55, and then you would complete what we're calling a homeless youth attestation. The link to that specific form is in the policy itself. There's a new form, it's the 5818. That form basically says that, yes, I am homeless and I am attesting to one of these two conditions. So whether they're homeless youth under the age of 18, they do not have a place with shelter, no supervision, no identified caregiver, or they're a runaway youth and they're receiving services through some sort of shelter, and they do not have an identified caregiver. In those two instances, they would be able to complete their own 50-55, and they would complete the 58-18, and that would self-consent them to health home. So this is the process that we've been following, because it's been a bit of a gray area for, I think, my entire time I've been in health home. But now we do legally have documentation that really formalizes the process that we've been using. Fortunately, it comes with an additional form, but most DOH policy does. Does anybody have any questions on this policy? Alrighty, you can go to the next slide. The next slide is the initiating and maintaining your level of care for OPWDD. There's absolutely zero changes to this. It was just an annual review. So you're going to follow the same process that you've been doing, which is helping support your members get access and OPWDD eligibility. Sometimes you're going to transfer them over. Sometimes you're going to keep them with you in health home. If you do keep them with you in health home, you're just going to make sure that once you now have gotten that eligibility for those kiddos, you now just maintain that level of care for them. So when they are ready to transition to OPWDD services, they should be all ready to go. Again, no edits whatsoever, just an annual review. Does anybody have any questions on that policy? All right, you can go to the next slide. Next, we have outreach and engagement. Again, just an annual review and no edits were made. This just goes through the process of outreach and engagement. What's your responsibility when you get a referral? That basically, you're going to attempt to outreach the client, get them enrolled, explain services. Nothing has changed there. That is all the same. Does anybody have any questions on this policy? Alrighty, go to the next one. All right, so I'm going to run through a couple of updates we've made to our quality assurance, performance improvement, and compliance policy. These updates were made due to our redesignation enhanced oversight plan. So as you all know, we went through redesignation, and from that, we have a couple of things that we have to follow up on. And one of those things was our quality management program. They just wanted to see a couple more things put in place. So we have formalized those in policy. So one thing that you'll notice is we have moved to what is called a targeted EOP. So that's a targeted enhanced oversight plan, and that's really there. So when we do your biannual audits on specific areas such as consent, eligibility, disenrollment, when we look at one very specific area of the chart that Taylor then puts in your quality notebook, we are looking for our CMAs to meet a 90% threshold. So let's say Taylor looks at 10 records. She's looking to make sure that your consents are accurate and appropriate. She goes in and 9 out of your 10 consents look good. So you've hit a 90%, no follow-up there. However, if you have 8 or less records in there that, let's say, meet compliance, now you're looking only at an 80%. So you'll be placed on a targeted EOP. It's really a very minor process. It's just something in place for us to really put a target there on something that we were already doing. You will not have to meet with us. You'll get a separate email that outlines just what you're put on this targeted EOP for. Hey, here's some helpful tips and tricks on how you can improve this specific area of your record. And then we'll take a relook at this in 60 to 90 days, depending on what it is. And of course, if you have any questions at any time, you can always reach out to us, but it is a way for us to formalize that 90%. And you may be thinking, well, that 90%, that's a bit of a high goal. However, we are held to that standard. So anything that did not meet a 90% target rate, we were placed on an EOP for. So the only way for us to avoid that EOP in 3 years when DOH comes back is to make sure that when we look at your consents, they're hitting that 90% target. when we're looking at your disenrollment, it's hitting that 90% target. Because if you're at that traditional 85 in those specific target areas, that would lead for us to be placed on an EOP. Go to the next slide.
So I just wanted to add to that, Jessica. So every audit that was pulled, every chart that was pulled during our redesignation through the charts, the auditing process, the 90% threshold was what was looked at. So anything that fell under 90%, we had to do a corrective action right up for that particular chart. So just so you're all aware that there was a lot of write up for us. So we want to prevent that moving forward. So we're trying to do that through our quality program so that it gets less and less and less as time goes on. So it's a preventative approach. This is what this is the thought process.
Okay, go to the next slide, please. Okay, so also in that, we have been monitoring and auditing your Health Home Plus. One thing we've always been looking at, and one thing that OMH really looks at, is that 50% threshold. As we went through redesignation, we did have a breakout session with OMH. We went over our numbers for Health Home Plus. So really, we're just maybe looking at really a little bit closer at your 50%. We performed very well in this area. It's just something that they wanted us to formalize a little bit more. So as you have your annual comprehensive audits that you have with us, we'll be touching base on this. Any of you who have had one with us in probably the last 6 months, this is something that we've discussed, just something that we're taking a closer look at. Now, if your numbers are way off, we may outreach to you prior to that year. Something else that Taylor's going to touch on a little bit later when it comes to Health Home Plus is we are taking a closer look at to make sure that billing is appropriate and correct, just because we do have some feedback from OMIG on our Health Home Plus billing, but Taylor will touch on that later. And the one thing we wanted to add in here, because we did have some questions on that, is really just clarity on how our records are sampled, who is auditing you. So just to let everybody know that we select 10% of your population, and we're going to select a cross between various populations. So if you serve adults and children, we're going to pull from each of those. We're also going to pull from various statuses. So we're going to look at people who are in diligent search, people who are in excluded setting, people who are enrolled, people who have disenrolled. Then we're also going to make sure that we grab some subpopulations. So if you have kids in HCBS, high fidelity RAP, adults that are HARP, Health Home Plus, we're going to make sure that we pull records from each of those statuses. So we're really getting a cross section of who we're looking at, and it allows us to kind of address all of those areas. Should you guys be doing a really great job in setting an example for our network, or maybe there's a deficiency in that area that we need to look at. Once we pull those records, a lead administration team is the ones who audit your records. So that would be the lead staff that you're already used to. We audit your records. Once we have compiled our audits, what we do is then exchange them. And then someone else is on the lead team has to then revalidate and verify that audit. So as you go through and you get your audits back, and Taylor's sending them to you in that PDF form, if you see a purple little bubble on your PDFs, go ahead and click on it, because that will mean that whoever has verified that audit has updated that score in some way or disagreed what was marked off, and then that could have changed your score and your outcome. So again, everyone is audited by a lead admin member, and then it is validated by somebody else, and there may have been updates to your scores. But as always, and you'll know this as you meet with us, if you disagree with anything that you were marked off on, we absolutely welcome feedback on anything. And we're more than happy to give points back. Also, we make mistakes as well. So please go ahead and if you have any feedback on your audits, we really do welcome that. You can send that to us hopefully prior to your scheduled meeting, but if you can't get it done prior, it's definitely something we can talk about before and then follow up post. Taylor, did you have anything to add to these updates? I'm not sure if I missed anything.
Just a couple things, nothing major. I just wanted, going off of the chart audit component, we do have a new, we discussed it a few months back, I think, a new audit refute form. So for those of you that do have, you know, things on the audit that you disagree with, like Jess said, we do like you guys to kind of weed through those and pick out things that you disagree with. It really shows us that you guys have an understanding of policy. So we do have a form that we can send you guys for that. It just is streamlined. You pop in the number of the question and it populates the text. It makes it a lot easier for us and for you guys to, you know, put feedback on it and give it back to you to let you guys know if we're going to give you guys points back on that. And then on the EOP, I just wanted to touch on that briefly. Like Jessica said, if you guys are on a targeted EOP for one of those biannual audits, it is going to be on the quality notebook. And then those of you that fell on one for your disenrollments, you probably saw I just threw in a highlighted sentence that said you guys would be receiving an additional email from me about the EOP. So in that email, that'll come sometime this week. It'll be your formal EOP documentation, as well as, like Jess said, kind of a guideline for tips and tricks on how to kind of improve that area and kind of what the time frame is for that EOP. So more to come on that for those of you that fell on that for the disenrollment. You guys will be hearing from me probably later this week on that. Thanks, Jess.
I just wanted to add one other
Oh,
thing too. A lot of times questions on policy start to come up too when we get to this phase, when the reviews come up and whatnot. Just a reminder for folks that, you know, we're always welcome to answer questions on policy and discuss policy. But we also have our resource for our policies on our website, and we go over this monthly on office hours as well for policy updates, and that's on a consistent basis. But those resources and policies are for everyone's availability on our website page. And we encourage folks to look at them and pull them, and you can download them and review them. And they're there for people to have as a resource. So please utilize that. It's there for everyone to have and to access. So, you know, we encourage folks to use it. It's there.
Alrighty, did anybody have any questions on the updates to the quality policy? All right, we can move on to the next slide. Next, we have our staffing qualifications policy. It was an annual review, not a bunch of changes, two minor ones. We just added some language in there about the HCBS certification that's going to be coming to the UAS. So if you serve children and you complete level of cares for kiddos that are enrolled in HCBS or looking to be enrolled in HCBS, you will have to have an HCBS certification. There will be more information to come on that. It is not live yet in the system. Secondly, when it comes to our HCBS kiddos, if you enroll or you hire a care manager, a children's care manager, and that children's care manager is going to be serving HCBS youth, not only do they have to complete when it becomes required in the UAS, that HCBS certification training, they also have to go through AHI training first. So if you have newly hired care managers and you need them to go through HCBS training, please reach out to me so we can get that scheduled. But moving forward, we're looking to have all of our care managers who serve that HCBS population trained by the health home and have their HCBS certification completed in the UAS. Does anybody have any questions on that? Alrighty.
Jessica, this is Raquel.
Hi, Raquel.
Hi. So Trish and I signed up. I'm just really confused about what we need for CAN stuff. So I know that's different than this, but
yep,
we signed up for things and then got emails back saying we didn't need to sign up for. So at some point I need to touch base with you about that.
Okay. I think, okay. Yes, you can go ahead and email me.
Okay.
I thought I saw an email from you and I responded. Maybe that's maybe I absolutely
did email, but I didn't get it. It's okay. I'll follow up with you. I just put it out there because I don't want to forget. And I know that we're talking about UAS. It's not the same, but it just made me remember.
Yep. So if you are, we can just touch base on the cans and the updated trainings there for a second. If you are a currently established health home care manager and you've been in health home care management prior to the last 5 years, we never had to attend that quote unquote live training or that what is now virtual training. That wasn't a thing. So there's a group of us that could have taken it because you wanted to take that pre-training and it was optional. There was a point when it became mandatory that everyone attend that quote unquote live training. What happens is now that they have the required booster trainings for everyone to take their annual CANS training, the prerequisite for that is that quote unquote live introductory CANS trainings. So some staff who have been doing this, like myself, since 2016, somewhere along the line did do it. And then there's some staff who didn't do it. So that's why I sent out those spreadsheets that had a breakdown of who needed to complete that introductory training and who had been set on that. If you still have questions, you can absolutely reach out to me. Sounds like you already did your introductory training and that's why they said you actually didn't need it. I will let you know that we have discovered an error in that spreadsheet that I got from DOH because they were telling me that there were a couple of care managers that weren't listed on there saying that they were good to go, and they absolutely were not. They really did need that introductory training. And then back in the day, it was also recorded on paper certificates, and they did try to go through those paper certificates to gather that documentation, but it could have been missed. But absolutely, we can connect offline. And then if anybody has any questions about the introductory training or getting your booster trainings done, please email me. And hopefully I can help you. If not, I can get you someone connected with you at the CANS Institute.
Thank you.
Of course. All right, you can go to the next slide, Travis. All right, transfers. So our transfer process is going to be changing a little bit. And we also have a formalized transfer policy from Department of Health. And it took, 12, 13 years for us to get one. We never really had a formalized transfer policy from DOH, and now we do. With that, there are going to be two types of transfers moving forward. One is going to be a member-driven transfer. So the member is coming to you and say, I would like to transfer from this CMA to this CMA in your network. Or you're working with a member and the member says, I would like a male care manager. You don't have one, so we need to transfer them to another CMA in our network. That is going to be a member-driven transfer. Then there's also what they're calling an administrative transfer. And some of you have been a part of these. They just didn't have this name before. This is when either a health home closes. So let's say a health home in another county closes and we absorb a couple of counties that they covered, and those CMAs come over to us. So that member is going to be changing health homes, but potentially keeping their CMA, or a CMA decides, you know what, we no longer want to be in the business of health home services. So they decide to close their doors, but their members need to be administratively transferred to a new CMA within our network. So there are two different types of transfers that are going to be addressed in this policy. It is a little confusing. Just think of your traditional transfer, as we discuss them all the time, as a member-driven transfer. And an administrative transfer would be something that we would walk you through, we would be a part of. It would be a bulk transfer of members. And there's some specific things that are going to vary health home to health home. So if your, CMA closes its doors and some of your members go to a different health home, they may process that bulk administrative transfer differently because every health home has a different set of workflows. So we would help you work with that health home to follow their policy. So in our administrative transfer policy, if the health home is changing, it's always from the view of that member coming to AHI's health home, because this will be our policy. You can go to the next slide. So the next slide is going to go over member-driven transfers. So something that we're going to start to implement is going to be called a transfer packet. What this is going to do is when you identify that a member needs to transfer to another CMA within AHI's network, you, the transferring supervisor, care manager, are going to work with Courtney on collecting a transfer packet. This will help the receiving CMA have something to start with when they start to serve that member, so you're not starting from scratch with that member. You're going to get a copy of the currently signed consent forms or forms, comprehensive assessment, a copy of the current plan of care, supporting documentation, obviously the transfer form, and if it's a kiddo, that HCBS documentation. Between the transferring CMA, care manager, supervisor, and Courtney, this packet will be compiled. And also, hopefully you're doing a warm handoff, having a meeting with that new care manager, and then this information will be disseminated. So it's as if the receiving CMA does not have to completely start from scratch. You can electronically enter that comprehensive assessment. You can electronically enter that plan of care. You can upload that eligibility documentation. You do have to get a new consent signed form because they have to consent now to enroll in your CMA. They don't have an option there, but you will get a copy of it so you have a reference when you go to complete that new consent form with that member. So this is going to be for member-driven transfers within the AHI network. Does anybody have any questions on this type of transfer?
I can say there's a number of CMAs that have given me feedback that they wish they would have had this type of information when they've received transfers. So I know that that's been feedback that I've heard, so I think this is going to be well received.
I've heard that feedback as well.
'Cause I often have heard that we don't get information when members are transferred. We're not getting enough information.
All right, if you wanted to move to the next slide. Okay, so now I'm going to briefly walk you through the administrative transfer process. This is all in policy. I do not want to overwhelm you. Again, you will only reference this when you absolutely have to, because all of your work is going to be under the basically that member-driven transfer. Michaela has a question. It says, is the new CMA just being added to the 5201 or 5055 and initialed? Or are they being added to the top of the form? So Michaela, you are going to get a copy of their current consent form, which should have the new CMA on that consent form. So let's say that I, Jessica Robertson, I'm enrolled at AHI. I would like to transfer to Hudson Headwaters so I can receive all of my care at Hudson Headwaters. AHI is going to meet with me, obviously discuss the transfer. They're going to add Hudson Headwaters to my 5055, work with the transfer packet together. They're going to communicate with Courtney that I, Jessica Robertson, would like to transfer for 3-1. They're going to touch base with you just to make sure you can accept the transfer. And then once I'm now transferred over to you and it's 3-1 and we meet to do my intake, you're going to do a brand new 5055 with me. So we'll meet, we'll do the intake, but then you also have copies of all of the other documentation to start as a reference point moving forward, so you're not starting from scratch. I hope that answers that question. All right, so administrative transfer. So there's going to be a couple types. So we're going to go over 3, I believe. So one, the CMA is going to remain the same, just under a new health home. So as you know, there's more than one health home in certain regions for a certain population. So let's say that that health home decides that they no longer want to be in business, but that CMA is under a couple of different health homes. And those members are going to be moved to a new health home, but the CMA is staying exactly the same. So the consent that that member currently has with that current health home, so let's say it's ABC Health Home is closing its doors and their members are coming to AHI, that consent that they have with ABC Health Home is valid for 56 days until a new plan of care is required. So that person is coming to you enrolled with an active consent form that is good for 56 days. So over the course of that next 56 days, you're going to want to get a new consent form. The CES tool will not carry over. It will be a year after the date of transfer. If the member is a child, at the HCBS and the CANS assessment, those are going to follow the child. You will not have to redo those. If it's an adult member, you're going to have to redo the comprehensive assessment. The plan of care will be done in 56 days. And if Courtney is using the transfer function in MAP, the eligibility screen will also follow the member. If not, you will have to complete that within 28 days. Amy is asking, what if a transfer is not planned? For example, I had a client move out of county. Currently, I did not get signatures. That's going to happen, Amy. Sometimes we have people that pick up and move to a new county and they don't inform us. In that case, you'll just have whatever you have, and then you'll put in the information, fill out the referral form, and you're going to send that to the health home that covers that new county. That's going to happen, and that's going to happen anywhere. So just do the best that you can. The transfer packet is really to ensure members who are transferred within the AHI network have everything that they need. And transferring to that new health home, each new health home has a little bit of a different process. So sometimes the CMA is going to change, but the health home is the same. So this would be if ABC CMA decided they no longer wanted to provide care management services. So those folks have to go to a new CMA, but they're still going to be under AHI Health Home. For those folks, the consent form that they had with ABC CMA, let's say they're transferring over to Hudson Headwaters, their 5055 or 5201 that they have on file with ABC CMA is going to be valid for Hudson Headwaters to use up to 90 days or for 3 segment months. Again, with the CES tool for adults, it's going to completely start over. You will have 12 months from the date of transfer. If the member is a youth, HCBS and CANS is going to follow the member. If they are an adult member, the comprehensive assessment will have to be completed. I keep saying adult member because as of 3-4, we'll get into it later, the comp for children will be in the UAS and it will follow the member. The member will have to have an updated plan of care and signed within 56 days. And if the closing CMA and AHI work together to get those members transferred using the transfer function in MAP, the eligibility screen will follow the member and you won't have to redo that. If we do not use the transfer function, that will have to be redone. You can go to the next slide. Next is when the CMA and the health home change. So let's say the CMA and the health home are exactly the same. They're no longer going to be in business. You got to go to a new CMA and you got to go to a new health home. If this were to happen, the consent that that member still has on file, again, valid for up to 90 days or 3 months. CES tool does not transfer. For adults, it will have to be redone. CANS HCBS will still follow the member, and for kiddos that comp, because it's going to be in the UAS. For adults, it'll have to be redone. And once again, the transfer function in MAP will allow that eligibility screening to transfer. If you don't utilize it, you'll have 28 days. And none of these administrative transfers, none of the member-driven transfers are applicable if you were transferring a member to a CCO for OPWDD. Please do not follow this policy for that. You're going to follow the OPWDD transfer policy. But again, when it comes to transfers, this administrative transfer is going to be something that happens very, very rarely. And when it does, we'll walk you through. So I wouldn't get overwhelmed with this administrative transfer piece, but I did want to walk you through some of the changes that have been memorialized in this new policy. Does anybody have any other questions on the transfer policy?
Jess, I have a quick question.
Sure.
So I thought when we transfer a member, technically we are disenrolling them from one CMA to the other. So how would consents remain valid if we're disenrolling them?
Yes. Okay. So for a member-driven transfer, so that is me, Jessica Robertson, working with Waite House. I go to you and I say, I no longer want to be working with Waite House. I want to go work with Michaela at Hudson Headwaters. You're going to put my transfer packet together. You're going to do the form. My consent does cease when you disenroll me. You will follow the disenrollment policy also. So you're going to follow the transfer policy with the transfer packet, You're also going to follow the disenrollment policy because I am choosing to leave Waite House and I am choosing to go to Hudson Headwaters. So when I move to Hudson Headwaters, I now have to sign a new consent with them. So that is correct. For the administrative transfer, which is going to happen in very rare circumstances, that's again only when a CMA closes its doors or a health home goes out of business, does the state allow for that consent form to stay valid so that member and new care manager can kind of get their bearings straight and you're not having to quote unquote re-enroll these members, that you have some leeway there, that consent is still valid. So in your day-to-day work, as you transfer people, you're going to continue to do it exactly the same, plus now this transfer packet that Courtney will help you compile. You won't
Okay.
be solely responsible for that paperwork.
Okay, thank you.
Mm-hmm. All right, Travis, you're up.
Right. Thank you, Jessica. Appropriateness criteria. Code. So I sent out this update last week. So Department of Health has put forward some new code updates for appropriateness criteria that's going to go in effect as of April 1st. The slide's got links to the charts and edits for the appropriateness criteria and codes. So you can see the links in here. I sent that out to the network. So for those of you that didn't get this through the email that I did send out, your supervisors would have gotten it, and you can connect with them and they can get that to you. But you'll get links to these guides here to show, number one, the appropriateness codes and what they mean and what they're in relation to both children and adults. And then also what the edits are on the other guide on the right for the appropriateness criteria and the codes and what they were and then what they are going to be moving forward as of April 1st. So let's get into what they will be on the next slides coming forward. So for the actual codes edited, so starting with code 10, this is going to now impact, it used to be just the adults. It's going to be both sides of the house now, both adults and children. And it's going to look at the appropriateness criteria for adverse events. And for adults, it's going to be looking at the current H code for EMEDNI for HARP eligible enrolled. And then for kiddos, it's going to be the current K1 code and EMEDNI for children's waiver enrolled. And it's going to reflect the addition of new criteria for children and now applicable to both adults and children. So that appropriateness code is now for both populations. For appropriateness code 13, the next code, that's changing for children to show within the last 6 months, to show an adverse risk event from Child Protective Service, Preventive Service Program, and wants to show that that's within the last 6 months. So that's a change that people should note. On the next slide, that used to be for both populations. Now it's striking out for children, and it's taken out healthcare risks during the past 3 months. The member has been unable to schedule and keep their healthcare appointments, medical, psychiatric, and it's struck out. They do not know who their provider is and how to contact their provider, and must describe the issue. So that is no longer part of that requirement. And that's just in particular to the children's population. Code 22, appropriateness code for adults. So recidivism risk, release from inpatient medical emergency department, that went from the last 6 months now down to 3 from a treatment setting. So that's a big change for the adults. So you're noticing the trend. This is getting more restrictive, which is not something that is a good thing. This did not go over well when the state presented this to the health homes. There was a lot of pushback. but here we are. 23, code 23 went from 6 months to 3 months. This was for recidivism, the release from jail or prison, other justice program. This is particular to the adults. Code 27, this is specific to children. And this was social determinant risk. Member has had a change in guardianship or caregiver within the last 6 months. And this didn't used to have a criteria assigned to the code, so this is a new thing. So it just reflects children in particular now. I was just going to pause if there was any comments or anything at the moment. Moving on, code 28. This is in particular, it was for both sides of the house. Now it's for adults. This is the social determinants risk. The member has had a change in guardianship or caregiver within the last now 3 months. It was 6 months. For now it's adults. It was for both populations. Now it's for the adults down to the 3 months. And then code 30, this affects both populations. This is for a social determinant risk. A member or caregiver, if the member is a child, is eligible for, is new language, and is to not have one of the following need entitlements. There's a note that has been added. Members who have access to the need benefit due to current enrollment is in a plan, program, or wherever do not meet this criteria. Example, given our members who are enrolled in Medicaid, managed long-term care, plan have access right through their MLTC benefit package, therefore do not meet their threshold for health home appropriateness if their only need is access a ride. Code 31, this is adult program. Reflects now time frame of 3 months, and it's an additional requirement of institutionalization or nursing home placement to be ongoing. And then code 32 for both populations has a requirement for a clinician's handwritten plan or prescription within the last 3 months now, and the clinician must be involved as to be specified for both populations. Any commentary or questions? This is a follow through, as I mentioned in my note initially a couple of weeks ago, that it's from the fiscal budget follow up from 23 into 24 for the cost savings from that 30 million, 70 million budget cycle. So it's still trying to correct that cost savings from that budget cycle. So this was another step in that measure to do so. And the Department of Health is trudging forward to do that. And there was a lot of pushback at the fact that this is really restricting our program that much further, and the fact that it's pushing into the children's program on top of the adults, which was not supposed to ever happen. But the Department of Health ultimately said we need to move forward to collect these cost savings to ensure that we don't have another cut in the future in the budget. Was clearly the message that was given to ensure that we don't have any further cuts moving forward. So that's where we're at with that. There's nothing with that. Those go into effect the 1st of April. If anybody has any questions or has anything offline they want to talk about on it, please reach out. If we don't have the answer, we'll definitely find out or have further dialogue. And we'll continue to work with you all and keep trudging along. But we'll keep moving on. So we'll move on to the telehealth guidance.
Hi, everyone. We're just following up on the telehealth guidance that was sent out earlier this month. We sent it out at the beginning of February. It just walks through some kind of interim guidance, really what it is. We do not have a formalized telehealth policy yet from DOH, but we do have a memo that they released that required some system modifications in NetSmart to kind of get going. So we have made those modifications in NetSmart to a certain degree to allow telehealth services. So there's going to be 2 new contact types added in NetSmart when you go to do a note. Those are going to be telehealth with a client. So that is your enrolled member. And telehealth collateral.
Well, we have that
Collateral?
training tomorrow, so I'll see you tomorrow.
Oh, yeah, see you.
Hang on once. Oh, I can't mute anybody
Sorry.
because I'm not in charge. And the other thing we have is telehealth collateral. So if you have a telehealth meeting with a virtual meeting with a school or another provider, you will log that in under collateral contact. Telehealth client or telehealth member is only to be used when you have a telehealth service delivered directly to the member that is enrolled. So only use that then, because we will cross-reference your note to that to make sure it was the enrolled member, because that is billable. That will count towards your in-person visits for a certain population. So it's super important that you're using this appropriately. We have removed video conferencing as an option to not make things more complicated than they need to be. We're doing our best. This is allowable for all populations, the telehealth option. So if you have an adult member, you can use telehealth. If you have a children's enrolled member, you can use telehealth. However, there are certain restrictions when it comes to telehealth. We will go into full detail on this when we do our core services and billing training policy for kiddos on the 17th. It is not to be used for folks that are enrolled in an AOT or Health Home Plus program. Those 2 programs on the adult side require an in-person contact. You cannot use telehealth in lieu of an in-person contact. So please make sure if you serve that population on the adult side that you are still scheduling with your members and meeting with them in person. There's a couple of other things that are not allowable via telehealth that still require an in-person component, and that would be some component of completing your plans of care, completing your CANs. We're still waiting on guidance from DOH on that. Right now, it excludes high fidelity RAP members. So if you're serving the high fidelity RAP population, you are excluded from being able to utilize telehealth. However, on April 1st, 2025, that will be an allowable option for you. For our kiddos, this is going to greatly affect your work moving forward because it's going to give you allowances to use telehealth in lieu of those in-person visits. It's allowed now. However, the children's billing questionnaire has not been updated to allow billing to process. So if you have started to utilize this, that's perfectly acceptable and appropriate. I would hold on submitting your billing until we update the CBQ, which I am being told will be completed 3/1, pushed out to UAT for the health homes to go in and test out, and then we will push it to production. At that point in time, go back and do your billing to make sure that you're getting paid for the work that you're doing. If you were to do it now, your billing would reject, even though it should go through. Again, this will be covered in further detail on the 17th. If you go to the next slide, that is the direct memo that was included in our communication out to the network. Does anybody have any questions about telehealth guidance that maybe I can answer until we wait for more formalized policy from DOH? All right, well, if you think of anything, please let me know. If you serve the kiddos population, please attend that training at 11 a.m. on the 17th, because we'll go into much more detail there. And it's punting over to Taylor.
Thanks, Jess. So very, very briefly, I just wanted to touch on gaps in care. Thank you to everybody that attended the gaps in care training. Last week, we had a really good turnout for that. It will be uploaded shortly onto the AHI website. In the meantime, if anybody wants a copy of the slide deck, please feel free to shoot me an email and I can send that over to you. We had a couple of good suggestions when we did the training, the first being for how to document the gaps in care documentation in the chart. Somebody suggested adding a new attachment category into NetSmart. So we have gone ahead and done that. So you guys will see that as an option now when you are uploading your documentation into the chart. You can select gap in care documentation as one of the attachments. And then the second great suggestion that we received was for kind of a manual or a guide on what the MCOs are looking for as far as closing those gaps. So we are working on compiling that for you guys. We're just, every MCO is a little bit different. So we're just working on getting feedback from the various MCOs on what their expectation is as far as what they require to get that gap closed. So as soon as we have that compiled, that will come out to you guys. But I just wanted to let you know that we are working on it and we will get it out to you as soon as possible. Next slide, Travis. Health Home Plus billing. So as Jess alluded to earlier, we have a little bit of an update as far as how we're handling discrepancies with Health Home Plus billing. So you guys know we've increased the oversight with Health Home Plus over the past year or so. We started doing those Health Home Plus spot audits, and through that we've noticed a pretty significant number of members with discrepancies in their billing category that was selected versus the documentation that's been uploaded into the chart. So for example, if we're reviewing a chart and the member has been billed for SMI, criminal justice involvement, but they don't have any documentation in the chart for that, but they do, however, have documentation for, like, say, SPOA clinical discretion. Our guidance thus far for those discrepancies has just been for the CMA to enter a note into the chart stating that the incorrect billing category was selected for, you know, such and such months. And then move on with our lives as to reduce as much administrative burden for you guys as possible with having to void and resubmit those HMLs. Unfortunately, like Jess said before, we've gotten some feedback from OMEG during this ongoing OMEG audit that we're undergoing that is just not going to fly as far as how they are reviewing those claims and looking at that Health Home Plus billing. So we want to let you guys know that moving forward, if we do find discrepancies in your Health Home Plus billing category versus what you have documentation for, we will be advising you guys to go in and void and resubmit Health Home Plus billing with the appropriate category for those months. So I just wanted to bring that to your attention that that will be our process moving forward, and we will no longer be just asking you guys to do a note. We will be having you guys void and resubmit billing as applicable for any of those discrepancies. We have done some targeted Health Home Plus trainings with some of our agencies. So if you guys feel as though you guys would like one for your agency, feel free to reach out, and Jess and I would be happy to do a training with your agency to just kind of reflect on the various billing categories for Health Home Plus, what's appropriate, what's not, and just level set for anybody that feels they need that. Thanks, Travis. This is me too. Okay, one more thing. So HCSCNI alerts in NetSmart. So we've gotten feedback and various reports from CMAs stating that there has been discrepancies with the HCSCNI alerts coming through NetSmart. So through you guys reporting those to us, we have been able to provide NetSmart with enough examples to determine what the issue, connection issue was between the two systems. So NetSmart has let us know that they have made system updates to fix the connection issue. However, if you still see or feel that you are having issues with your alerts, the first step is going to be to please re-trigger the HCSCNI consent in NetSmart. And then if that doesn't work, please report the issue to the Health Home email, and we will compile that information and touch base with NetSmart to figure out what is going on. So just a heads up that that has been resolved, and you should be getting your HCSCNI alerts flowing properly now. Put it back
Alright.
over to you, Jess.
Yes, we're gonna walk through some children's updates. First update we have is the CANS updated algorithm. As we all know, the Department of Health came out and did state that there were some issues with the CANS 2.0 algorithm. And we had those spreadsheets compiled that have been sent back to Courtney. The update I have there is that this week, Courtney is going to start working on getting those HMLs resubmitted. So everyone has sent her those spreadsheets. She knows what month she can submit billing for at the higher rate. So she's going to start working on getting those claims submitted at the appropriate rate. So we've got that going on. Secondly, there will be a second batch of updated billing that we have to do, and that will be for December of 2024, January and February. So anyone who had a CANS completed during those 3 months and it came out incorrect, those folks are going to be updated, and then we will have to redo this process again. However, I do have some promising news on 3-4. You guys all received communication through the UAS. They are updating that algorithm on the back end. So come 3-4, any CANS that is completed will be done correctly at the correct algorithm. So once we hit 3-4, any CANS that is completed will have the updated new algorithm. So moving forward, those should all be coming back at the correct acuity rate. Also, with the level of care billing, that has all been completed. We are still waiting on the rejections for those. Once we have that billing rejection, we're going to get that sent out to DOH for payment. Does anybody have any questions on either of these two things? All right, you can go to the next slide. Next, a little update for our high fidelity wrap CMAs. Some of the forms are in NetSmart for you to start using. They're going to be on the bottom left-hand screen. It's going to say high fidelity wrap dash needs inventory, child and family treatment team meeting, family story. The one thing that I do want to point out, and this is going to be for everybody, and we are working with NetSmart to see if we can get it fixed, because this form is not just used by AHI, it's used by all health homes, is the interdisciplinary team meeting IDTM in parentheses is for high fidelity wrap members. The other selection is the interdisciplinary team meeting form that you're all used to using. If you accidentally open this, you're going to be like, what the heck is this? This is not the right form. It's asking me weird questions. Hopefully that will trigger you to take a relook at that, those tabs and select the correct tab. We're working with NetSmart to see if there's something we can add to this to specifically call out that this IDT meeting is specifically for our high fidelity wrap members, and that mainstream health homes should be using the other form. So I did want to call that out, just in case anyone was confused while there were two in there. So we are working on that. Next, I have what could be some exciting updates for our kiddos in the comprehensive assessment. Part of that 3-4 release in the UAS that's going to fix our CANS algorithm. It will also it will also incorporate the children's comprehensive assessment right into the CANS. So as of 3-4, as you go to complete your CANS, you're going to be completing your comprehensive assessment at the same time. The UAS sent a memo out on 2/18 to every UAS user. So make sure if you haven't read that memo, you go back and take a look at that. It walks you through everything. Also, when you log into the UAS and you go to select your user role, it will tell you that you have required reading that you have to complete. This is also part of that required reading, just to let you know, hey, it's here. So as we move forward, some of your comprehensive assessments will be done at the same time you're doing your CANS, which will mean that you're no longer using the comprehensive assessment form in NetSmart for kids. So that comprehensive assessment report in DataDen will slowly start to show that you have people overdue. That will probably run for about a year, because it's going to take us a year to get caught up from 3/4/2024 to 3/3/2025. it will take us to get everyone to get their updated cans into the UAS, which will also align with the comprehensive assessment. So, couple of things going on here. If your CANS due date and your comprehensive assessment date are relatively close to each other, you can let your comprehensive assessment date kind of go over and past due so you can align it with your CANS date. If your CANS date and your comprehensive assessment date are really far away and your comprehensive assessment is going to be egregiously overdue, then go ahead and use the NetSmart comprehensive assessment. And then when you go to do your next CANS, it will catch up. There's not a hard and fast rule. We have not put, a difference of 90 days or 60 days, 120 days. I would say anything over 3 months, you should probably go in and do the comprehensive assessment. But we will keep this in mind as we audit moving forward, as we do your notebooks pertaining to kids, that there is going to be a discrepancy between DataDen, what's recorded on your notebooks. Taylor and I are working on a solution for that. But as you guys update your CANs for your folks for 3, 4, and after, it will be combined into one assessment. Does anybody have any questions on that? All right, go to the next slide. Again, on this slide, just reiterating that core services billing policy. Again, we got that training on the 17th at 11. We are in our final stages of that policy. It's about to be finalized. I am waiting for what DOH is calling tweaks to the policy. But we're forging ahead. When we get those tweaks, we will update it. I don't think they will be major. They did not say they will really affect most of your workflow, but that remains to be seen. So we are moving ahead with that. We are moving ahead with the training. That new policy will be effective for 4/1. And then lastly, we do have a new policy coming out. It was issued last week, I believe, and it's going to be the SPOA referral process for HCBS members and folks who are high fidelity RAP. So there's going to be a new specific policy for CMAs to follow, health home care managers to follow, supervisors in the lead health home that we have to follow, specific to when a children's SPOA referral happens for somebody who is HCBS, pursuing HCBS, or who would like to access high fidelity RAP. So we're going to treat these referrals exactly like they're coming from CS. And anybody who knows, if you ever get a referral from CS, it flows through, or should flow through, the health home first to avoid complication, because we don't always get the exact correct documentation, and then you are responsible for that. So if you were at any SPOA meeting and you were being handed a referral and the SPOA coordinator has already started the process for pursuing HCBS level of care, has HCBS level of care with a K code, or will be pursuing high fidelity RAP, you need to immediately notify myself at the health home in order to follow up on that referral. You can tell that SPOA coordinator, can you please send that directly through the health home? We will obviously disseminate it down to you, but what that will do is allow us to double check to make sure that that is all set for you. I will be reaching out to all of the SPOA coordinators that are in our network, just to give them a heads up that this is going to be how referrals are processed moving forward. And then again, next month, we will have a brand new policy that really formalizes this process. Does anyone have any questions on either of these two things? All righty, Travis?
All right, thank you, Jess. Thank you, Taylor. Last thing I had today, I just wanted to give everybody an update. We have the 3 organizations in yellow here are actually going through various stages of onboarding right now. We actually just went through yesterday an organization called Change by Christ, went through its first day of onboarding with us, and we're going to be meeting with them again tomorrow. So they are in process of finalizing their onboarding, and they will likely start attending office hours next month. And so So we're excited about that. So we'll share more information with them. They're out of Plattsburgh, so they'll be serving Clinton County. They'll be serving the adult population. So we'll welcome them a little bit more next month, but we're really excited that they'll be coming on board. And then also Step by Step, they're out of St. Lawrence County. We're actually next week driving up to Plattsburgh to meet with them to do their first day of onboarding training. So they'll be finalizing that next couple weeks as well with us. So they'll be up and running within the next month out of St. Lawrence County. So they'll be providing services for adults as well. So we'll have some more information coming and have them joining us in office hours, if not in March, definitely in April. So those are two organizations that'll be up and joining us in the next month to month and a half. And then People USA, they're actually home based out of Poughkeepsie, New York. And they're with another health home out of that area. They're operating a care management agency down that way and have done for some time, but they're also going to be starting a care management organization out of Warren County and serving adults. And they're going to be starting with us. And they're ready to go, barring they complete the onboarding. They're just finalizing their staffing, and once they get their staffing identified, we'll be conducting the training with them. They've completed all the other steps up to that point, so we just got to do the onboarding training piece. So we're excited to hear from them shortly once they have their staffing identified. So we're looking probably in the next couple months, ideally here, to have them up and running with us as well in the network. Again, focusing on Warren County, and they would be serving adults. So it would be 3 new organizations serving the adult population. One in St. Lawrence County, which would be Step by Step. Changed by Christ would be Clinton, and then People USA would be out of Warren County, all for the adult population. And then we have Saratoga Hospital not too far behind, and then Unlimited Potential and would be Saratoga County, and then Open Door would be Warren County. So those are the 3 other organizations, all of which would be serving adults once they get up and going, as they continue through their red tape to become a provider approved in the network. So a lot of movement in the last few months for those organizations that are in yellow right here. So we're excited. So I just want to share that good news. So we'll be welcoming those folks on board here in the next office hours. Yay. So that's it for today. A lot of information. Had a lot of policy updates the last handful of months here. A lot of changes in policy from the department, but we've had to get them up and through. So apologize for the big influx, but have to get them updated. So, but any questions, please let us know.
Travis, we did have one question. Marcus is saying in the comp, there is a question about how many drinks. Yes, Marcus, we are aware. Unfortunately, with that specific question, you just have to select something. That is a standardized assessment that we cannot change. So we are aware, hopefully, the adult comprehensive assessment will also be updated, and that specific screening will be pulled out of there. But for right now, we do have to comply for what is in the record. And I apologize in advance.
All right. Anybody have anything else? Again, thank you as always for everything you all do, and I hope you all have a great rest of your day.
Hey,
Catch you
Travis.
next-
Well, people are
Yeah.
already leaving, so never mind, I guess. Sorry, it took me a minute to unmute. I just wanted to share with everyone who is here. I had a conversation today with Cassandra Becker at MAS, and among the things she wanted everyone in our agency to know is that they're starting something. MAS is working on something they're calling a PPO, a preferred provider opportunity, in which they are working directly with institutions and taxi companies to set up preferred providers for cab rides for that agency. So right now, places that down in the Albany area that provide outpatient substance abuse services, there's 7 of them in particular, where we can no longer set up rides for them. The provider has to set up the rides themselves. So they're rolling this out. There'll be more information about this coming down the line, but she just wanted me to, she asked me if I would let everyone know that this is something that they're doing.
Okay, thank you, Rob.
You're welcome.
Anything else anybody wanted to share? All right. Well, have a great rest of your day, everyone. Thanks again.